Henry Yan.
Alright, so I'm here with two of our medical students.
A fourth-year medical student and going into obstetrics and gynecology next year.
I'm also a fourth-year medical student going to emergency medicine.
And when did you guys first start learning ultrasound?
I started as a second-year medical student. We had a few opportunities to get involved here at Ohio State, and one of those opportunities was being a T-sub ultrasound model for some of the more advanced students in their ultrasound education. So I started out just by modeling and attending some didactic sessions on how to obtain certain images, and have been heavily involved in the ultrasound program ever since.
So I started my first year with the Trinity ultrasound program here, and really my learning with ultrasound has really ramped up during my third year through the advanced competency, during my fourth year through the honors ultrasound program.
And why did you guys engage in these processes to start? What made you want to learn ultrasound?
I thought it was just a really unique opportunity that we had here at OSU, that in talking with other of my fellow medical students at other universities and institutions, they just didn't have that available to them. So I didn't know what I was going to be going into back when I started ultrasound, but I thought what a great tool to kind of have in your back pocket, whether you go into surgery or GYN or emergency medicine or even internal medicine, something that is pretty readily used in almost every specialty. So
I kind of got roped into it incidentally, but then I got hooked onto it because of the idea that this is something that I can learn and really become comfortable with, and then have an impact during my third and fourth years clinically.
Okay, great. Now, since you started using ultrasound so early in your career, even when you were third years, you probably saw some incidents where ultrasound could easily have been applied and maybe wasn't, or wasn't being used correctly by your senior faculty, residents, even senior medical students. How did you handle those kind of situations?
You know, by the time I actually got comfortable using ultrasound here with some of our models, or just using it on one another to learn, it was kind of early on in my third year when I saw maybe some things that could have used a correction or two while I was on the wards. Specifically, one story I remember when I was on the neuro ICU, I had a senior resident was trying to put in a peripheral line with the ultrasound machine. I was really struggling not only to identify what vessels were what, and spent over about a half hour trying to put this arterial line in this gentleman who was in quite a bit of pain at that point. But I don't think I had built up the confidence and comfort with ultrasound to kind of step in and say, hey, there's a few extra things you could probably do to help ease your procedure here. So that's just kind of one of the first times I realized that ultrasound was being used all the time in the hospital for a lot of different things, but sometimes was not being used as effectively as it could be.
I really haven't seen too much of ultrasound being misused. I've seen it being underused, especially in my current rotation, which is at an outside hospital. They don't have an ultrasound machine in their medical ICU. And just today we rounded on 3 patients with congestive heart failure who were hypotensive. And the question was raised whether we give fluids or not.
And you
I
had an
gently
answer.
suggested that we do the IVC ultrasound.
Yeah.
But that would have entailed me going all the way down to the trauma bay, taking their ultrasound, the ED not having an ultrasound for a little while, and then having my attending come in and having us both scan so that we could actually use those scans. And we ended up just putting in central venous access and getting a CVP instead.
And did that help?
It eventually helped, but it could have been done more quickly.
Yeah. Okay. Have you ever found, now after you're now into your fourth year, where you have the skill that those around you maybe don't have, in situations like what you just described, where you want it to be used but maybe people aren't comfortable with it, even if it's available to you and it's sitting right there and you just want to turn it on, and that's like the biggest hurdle to get over for the rest of the team, is that turning the power, where the power button is, and using the machine?
Pretty much all the time now. I just got off of my emergency medicine rotation, and every day, like, the first thing I did after I met my attending was like try to locate where the ultrasound machine was. It's because I knew there was plenty of opportunity to do scans scans and things like that, and maybe some of the interns or even senior residents who were a little busy running around and attending to patients maybe didn't have the time to go and actually do scans themselves. But I remember I was at my OBGYN rotation actually at an outside hospital here with one of the interns, and we had a mom come in who was late in her pregnancy and was just concerned. She didn't feel the baby moving, so we were just going to do an amniotic fluid index, and so we dragged the ultrasound machine into the room, and I thought, oh great, this is one of the first times, this is before my EM rotation or anything, that I actually get to use ultrasound in the clinic setting. How cool, and I'm pretty comfortable now with it or whatever. And she went in and was kind of moving the probes. I'd never done an AFI before, but I knew the basics of what we were looking at for that kind of deep pocket, the same thing we do for ascites measurement or things like that. And she was kind of moving the probe all around the patient's belly and all three planes at the same time. And I was kind of cringing in the back of my head, saying, "Oh, there's a really systematic way to do this." And
your ultrasound instructor would be
she
so mad.
She just didn't know. And so I said, she actually told me verbatim. She goes, "I don't know really how to describe the movements to you, but you just kind of move around so you find that deep pocket." I thought, "Oh, what a great time to stop and be like, oh, well, I can, maybe if you want to learn, can teach you some of these movements. They all actually have names, and if you do it in a nice systematic way, you sweep and slide and then kind of rotate and find your pockets." And just that was information that was not available to her in her training, but that I had, and so I was able to kind of, after we were done with that patient, sit down and spend 5 minutes teaching. So it was kind of nice.
How was that received?
Pretty good. I think we're in a field where learning is a ever-present part of our career, so I think people are very receptive to being, oh, you have a skill that I don't have. Let me take this as an opportunity to learn. Yes, you may be junior in rank, but you have some valuable information that could kind of help with clinical decision making or anything here on the ward. So that's pretty well received, as long as you don't act like, oh, I know everything about ultrasound and you don't know anything. And they're like, yeah, well, I'm a resident, I do this every day, I know a little bit. So just got to find the right tact.
Yeah, I think being humble about everything is really the way to go. There was an incident when I was on an ED shift where we had a patient come in acute respiratory failure, got intubated, and it turns out the next day I was supposed to present the blue protocol by Lichtenstein on lung ultrasound in dyspnea. So I actually had the article with me because I was going over some of the finer details for my presentation, and we sat down with the article together, went over some of the key points on how to do the lung scan and what we were looking for, and then we were able to do that while we were waiting for the patient to go up for his CT scan.